Our next speaker and our keynote speaker is Dr. Joseph Misdraji, and he is the Director of Surgical Pathology at the Massachusetts General Hospital and Assistant Professor of Pathology at the Harvard Medical School. And if anybody was here last year, you may remember he gave an incredible lecture on on basic pathology and pathology of appendiceal cancers, which is not an easy topic. And so, as I mentioned earlier, this year we had our there is a biannual, very large international conference dedicated solely to intraperitoneal cancers, of which the appendix is obviously one. And there was, over the course of the last year, there's been an international effort at a consensus to better help us describe and communicate about what type of tumor a person has. Dr. Misdraji has played a huge role in that consensus. It's not completely, right? There's still a ways to go. Is anything
ever complete?
But he can give us an update on what the consensus was, and it was great to have him and just another group of dedicated pathologists who are so essential to helping us treat people as best we can with this disease, to be there in Amsterdam and to bring their expertise and their knowledge. So thank you very much for coming again this year.
Thank you, Laura. So thanks to Lord for having me here again. And what I'm going to attempt to do in the next maybe 40 minutes or so is talk to you a little bit and hopefully get you to understand why there's been a lot of controversy about the pathology of this tumor. And in particular, one of the challenges of this tumor of many appendiceal cancers is precisely that, is that there's been a lot of controversy over whether we should call them cancers, which leads to a lot of confusion when someone goes to one institution where they don't consider them cancer, then they go to another institution where they do consider them cancer, and you get different names for the same tumor. And of course, that might lead to a different impression about what you should do, and certainly a different sense of urgency about whether you should do anything at all for these tumors. And so I'd like to take you through how that controversy developed, and then, as Laura said, through the Peritoneal Surface Oncology Group International, a 2-year effort has been underway to sort of see if we can establish consensus criteria and a consensus classification for these tumors. Does this work? Okay. So in case you are not aware of where the appendix is this finger-like little organ, really small, but obviously it can be the source of a lot of problems for some people. It's right at the base of the colon, where the small intestine attaches to the colon before the colon makes the rest of the route to the rectum and anus. And this is what an appendix looks like if you remove it from the body. This is a normal appendix. Here it's been taken off from the colon, and you see it looks very much like a pinky finger. And then there's this sleeve of fat that's also been cut off. This is where the blood vessels go into that appendix. And you can see it's pretty uniform throughout its length. It's not dilated, just like a pinky finger. And if we take a slice through that pinky finger, like you might do through a sausage, this is what the appendix looks like under the microscope. And it's a little bit bigger than this, so I'm just focusing on the very center where there's a lumen or a hole in the center. And it's lined by epithelium. Epithelium lines all our body cavities, and it certainly lines the lumen of the appendix. And it's lined by 2 types of cells. This is throughout the colon, one that absorbs water. So of course we can make stool from all that watery stuff that's going through intestine. And the second is the occasional cell that produces mucus, because we need to lubricate stool so that it does move through the colon and doesn't get blocked up. And the occasional little clear bubble cell are the ones that are producing mucus. And you can see they're kind of a minority. And you can see that the epithelium goes up and down into what's called crypts or glands. And this entire structure, up to this little bit of pink here, which is a little bit of muscle, this entire structure is called the mucosa, or the lining of the appendix. And you can also see that the appendix has some blue nodules in it. These are immune cells, probably because the appendix might have some role in teaching our immune system how to handle all that bacteria in our colon. And then what you can't see here that I couldn't include in the slide is way out here, you have a really thick wall of muscle. Throughout your bowel, there's a wall of muscle that squeezes the material through like a toothpaste tube and keeps it moving. So this is another person's appendix. Now you can see this is very different. Now this one's dilated and it's filled with mucus material. And this is what we would call a mucocele, which just basically means a cystic dilatation, and you can see it looks dilated like a cyst, and the muco part is mucin. It doesn't exactly tell you what's wrong with it yet. You're going to need to look under the microscope. So this is a very general term for dilated appendix filled with mucus. And when you look at an appendix with one of these tumors, this might be one of the appearances that you see. So rather than having that mucus layer that had all the glands going up and down, instead, now we have a growth of predominantly all those mucus cells have kind of grown a little bit more uncontrollably. They don't look horrible, but they're starting to grow like finger-like growths into the lumen. You can also see we've lost those blue nodules. That's fairly typical of this tumor. Can everyone hear me okay, by the way? Okay. This is a comparison of what we saw before, the normal. So you can see it doesn't have the finger-like growth. It has more like these deep pits. And then the opposite here, where the tumor is mostly those mucus cells that are now growing into the lumen like villi. Now, as the appendix dilates and gets more cystic, that pressure can cause those villi to sort of get flattened. And this is the same tumor, just a very different appearance. Now, instead of those finger-like projections, we just have this sort of little tufted appearance around the edge, but it's the same tumor. So here's another case. And in this case, you can see once again, the appendix looks dilated. It looks more like a thumb than a pinky. And it looks like the outside looks fairly smooth, except for this little nubbin of mucoid tissue and a little bit of hemorrhage here. And it looks fairly innocuous, but it's that tiny little plug of mucus that is the point through which that tumor that I just showed you in the appendix lumen managed to escape into the peritoneal cavity and into the abdomen. And this is that same patient who you could see, even though that was just a tiny little innocuous looking little plug of mucus, this is their omentum. So this is the colon traveling here with that muscle wall and some fat. And this is the omentum. The omentum should look like a combination of fatty tissue on cellophane. So it should look really thin, perhaps like we see here. It looks like some cellophane up here. But this kind of foamy, bubbly tissue that is clinging onto it is all abnormal. And here is another area where, again, you could see the massive infiltration of the omentum with this tumor. So all this material that looks foamy and bubbly is abnormal. Here's a large vessel. That's normal. So you can see how it's completely encased this omentum, and sometimes what's called an omental cake. And if you take a section of it, again, this should be as thin as cellophane. And you can see that it looks like bubble wrap, very thick. And it has the consistency almost of like a slimy styrofoam sometimes, or more watery. So kind of a variable, but this one looks like it probably was a bit firmer. It clearly looks like you could cut right through it. So when you look under the microscope in a lot of these cases, interestingly, there is a lot of mucus. And this is what mucus looks like under the microscope. It's this blue kind of pooled material here. There's a little bit of collagen here from the structures underneath. Everyone realizes that this is a slowly progressive disease that needs to be treated aggressively no matter what terminology they're using. But that nomenclature issue causes problems, not just for treatment, but even for research. I was intrigued that Dr. Lambert presented one of the studies where I guess they didn't have a pathologist on their study, but they showed the genetic changes in these tumors. And they said one category, if you notice this, one category was tumor, no cancer. What does that mean? Tumor, no cancer. So it becomes very confusing when people use terminology that just doesn't really conform to what everyone else is using. And sometimes research data is lost because people are using categories that you're like, I don't even know what that means. So I can't apply that to my database, or I can't compare my data to theirs because I don't know what they used for categories. So there have been arguments for saying that this process isn't cancer. So, of course, some of the things we've talked about, it doesn't look like cancer. Cytologically, the cytology of the cells, what they look bland. Another thing is the appendix doesn't look like your usual cancer, where I showed you the little glands infiltrating. Also, even though this spreads to the abdomen frequently, it tends to coat the organs inside the abdomen and doesn't usually spread to lymph nodes or outside of the abdomen, like cancer usually will eventually spread to the lungs or other parts of the body. And of course, people have compared the prognosis of pseudomyxoma to things like colon cancer when it spreads. And colon cancer, typical cancers, when they spread to the abdomen, are far more aggressive than pseudomyxoma. So people said, well, the prognosis is very different, and it's better than people with cancer. But then there have been those people who say, absolutely, we should call all these things cancer, and I mentioned some of those. Anytime you see spread of cells outside of the colon or outside of the organ from which they came, that's got to be called some kind of cancer. And these people also say, well, you know, you can look at other organs, like the pancreas, for example, and you can get tumors that are very bland, but they're cancer. So the fact that they're bland doesn't absolve them of being cancer. And of course, they also say that despite the better prognosis, pseudomyxoma is fatal in many people if you do not manage it aggressively. And so they say anything with that kind of biology should be called cancer. In 2003, we waded into this quagmire by looking at a bunch of appendiceal tumors and trying to come up with a name for them. And we recognized that there was a huge controversy with calling them an adenoma, and some people didn't want to call them adenocarcinoma. So in classifying our tumors that I showed you that had this pushing, we gave them a name that was sort of in between. We just said, well, let's just call them a neoplasm, a tumor, low-grade appendiceal mucinous neoplasm. And that way we all know what we're talking about. We're talking about this tumor that people are afraid to call benign and not willing to call malignant. And so sometimes it'll go by the name of LAM. And in 2010, the World Health Organization adopted this term for this type of tumor with the caveat that it's listed under the types of cancers. So, you know, we were kind of non-committal. They committed it to a form of cancer. So over the years, because of this controversy, there have been a lot of classification systems that have been put into place. Dr. Carr will actually come into play later when he's the one who headed this pathology group at the international meeting. But they, from the 1990s, had a nomenclature. We came up with ours in 2003. Other people have added theirs. And in 2010, you would think that the World Health Organization would put this to rest by sort of selecting from the best of these classification systems and coming up with a consensus classification system. But nothing is perfect. I want to also return back to this idea of the tumor in the abdomen for a moment. We've been focusing on tumors that are low grade because that is the most controversial area. And this is an example of one of those tumors that has a lot of mucus, and here's a ribbon of tumor cells that are mucus producing, but look at those little nuclei, they look so tiny. So this would be one of those low grade varieties. It might be called DPAM, for example. But there are certainly some examples of this disease that are much more aggressive looking. So you can see by comparison, this is much more complex. It's not just little C-shaped ribbon now. We're seeing this real growth of cells, or here, a lot more tumor cells and a lot more complex growth. And when you look at this under high power, here again, a normal cell to get your bearings. Look how large these are and jumbled. They have these purple dots in the middle of them. These are called nucleoli that you see in much more aggressive tumors. So there wouldn't be much controversy here. This would all be called cancer. So there are some people whose pseudomyxoma looks worse. It looks more high grade. Less controversy there because everyone would call that cancer. And in the 1990s, this is the group that came up with DPAM, and they showed that people with very low-grade bland disease, no surprise, did better than people who had more aggressive-looking disease. And this has been borne out by other groups. So for instance, Bradley et al. Showed this. If you look at people and their tumor in the abdomen, the pseudomyxoma, people with low-grade disease do better than people with high-grade disease. But they did not like this DPAM terminology, so they changed the terminology, and they called everyone mucinous carcinoma peritonei low-grade or high-grade. So you can see that kind of controversy. They refused to call it DPAM. More recently, there's been additional work that has come out in the last 2 years that have shown that people who have Signet ring cells in their peritoneal cavity may do worse than people who don't. And what are Signet ring cells? Here again is fatty tissue and collagen. These are some inflammatory cells. The tumor cells are these little ring-like cells. You can see they have a little cup of mucin and that little kind of dark nucleus on the edge, and they're dispersed individually. Signet ring comes from the name of the ring people would use to impress on wax their seal, and that was a signet ring. And you can see what they look like in different areas. This is probably the best picture. So you can see they have a big blob of mucin in them, and then this flat nucleus pushed to the side. So why would these be any worse than anything else? Well, the reason is you can see that they are not holding on to each other. They're very individualistic and solitary existence. And the other cases I've shown you, all the tumor cells all held on really tightly. And if I'm a tumor and I'm trying to get across the room and I'm holding on to other tumor cells very tightly, so we're 50 guys all trying to get through you, you could probably stop us because we're 50 people trying to get through you. But if I let go of them, and now we're 50 people individually running to that side of the room, we'd be a lot harder for you to stop. And that's the issue, that single cells by themselves can infiltrate tissue much faster and more aggressively than a big wad of tumor can, trying to hold on to its neighbors. And so what they showed in 2013, and actually there's been another paper that just came out this month that repeated this data and shows the same sort of thing. People who have very low-grade disease, or DPAM, which they called pseudomyxoma grade 1, do better than people who have high grade. And grade 3 they added is anybody with signet ring cells. Now there's a little problem here in that usually when a pathologist sees signet ring cells, we need to see half of the tumor be signet ring cells before we're willing to call it a signet ring cell cancer. But what if you see 40% or 30%? That's probably still not good. And they said any amount of signet ring cells. Well, then you start saying, what about 1? How about 2? So you get into this question of what are your thresholds? When is it really bad? And that's data that still needs to be worked out. But you can see now what we're starting to get in is it better to have 2 tiers, low and high, or is it better to say there's 3 grades in the peritoneum in pseudomyxoma, low, high, signet ring? And so that's what they proposed here, and this paper just recently also proposed this. And I think that this is probably going to bear out. So how are we trying to build consensus? Well, about in 2013, it was Norman Carr from one of those earlier papers who had the idea through the Peritoneal Surface Oncology Group International to start convening pathologists who had an interest in this area to see if we could build consensus. And it was actually done through electronic means, people emailing each other, do you know this person's email, do you know that person's email? And essentially, after a while, about 70 people were invited to join this, and about 40 or so people did join. And they went through a modified Delphi process. And what that means is you send out electronic surveys and you all answer and say, this is what I do in my practice. We pool those results and then we give it back to you. And you read what everyone else said, which makes you rethink your own answers. And then you do another round of surveys. And then you pool those answers, give everyone those answers, and you keep going back and forth. And hopefully by reading what everyone else is doing, and maybe if you're an outlier, you might modify your answers and your way of thinking to conform to what obviously is the majority opinion. After the first round of questions, we met in Basingstoke, England in 2013. And this is the most interesting piece of information that came out of this, which is that despite the fact that we're all experts, none of us was doing the same thing given a same case. And I think it's most dramatic here. If you look here, so these are the respondents of the survey. And you can see that there are certainly some people, groups of people that do the same thing, but there's one person here, so there's some outliers. Let's just look here as an example. This is a tumor with that pushing invasion, which I've demonstrated to you. And you have some people who are calling it a low-grade adenocarcinoma. You have some people that are calling it a ruptured adenoma, the extreme opposite, and a whole bunch of people that have adopted the use of LAM. There's some people that have even come up with a LAM2. Who knows where they came up with that? So you can see that people just sort of modify their practice to what they think is best and appropriate for their patients, but may not really communicate when you start going from institution to institution. Additional 3 rounds of surveys were done, and those results of all of those were brought forth in Amsterdam. Now, what they brought forth in Amsterdam, because it may seem a little underwhelming, there's a lot of people who practice, and we had to make sure that what we presented to the group in Amsterdam was what everyone agreed we could say. And so there had to be a 2/3 majority that agreed to these statements. And so what was agreed amongst this group of pathologists is that they would adopt the term LAM for those tumors that are low grade and have this pushing look through the appendix. Now, actually, it's interesting. You actually sometimes, I didn't show you this, but sometimes you'll have that same pushing look, but when you go look in the cells on high power, they look awful. And then what do you call it? And so they agreed on this term high-grade appendiceal mucinous neoplasm for a tumor that has pushing, not obvious invasion, but when you look at the cells, they don't look so good. And then we will reserve the term mucinous adenocarcinoma for those cases that have bona fide invasion with the little glands, like typical colon cancer, or like I showed you, you can get in the appendix. And then what about turning to the pseudomyxoma part, because that was the appendix part. One thing that was clear to everybody is that the grade of the appendix tumor is less important, actually, for prognosis than the grade of the peritoneal tumor. They usually coincide, so if it's a low-grade appendix tumor, it's usually a low-grade peritoneal metastasis, but not always. And it's more important that people report the grade of the peritoneal tumor, something that many pathologists might not even think to do. And so that was one thing that came out, that the grade of the appendix tumor has to be distinguished from the grade of the peritoneal tumor, and both must be reported. There were some people who wanted to say that if you had a lymph node metastasis, we would automatically say that was high grade. And a lot of people voted that down and said, no, lymph nodes are different than grade. And so that was kept as a separate issue, and each one of those assessed separately. And then finally, this issue of signet ring cells. As I mentioned, if you have over 50%, everyone was clear that you would call that a signet ring cell adenocarcinoma. But what if we had less? We would agree that if it was less than 50%, we would still report those as being present in this way, poorly differentiated adenocarcinoma with signet ring cells. And so again, being able to communicate what that means. What are the next steps? Because this is the Peritoneal Surface Oncology Group International, and I can tell you the truth that a lot of practicing pathologists probably haven't heard of PSOGI, which has that unfortunate acronym that is unpronounceable. So what are the next steps for this group? Well, one is to write a position paper. That can get published in a journal that says, as a group of experts, this is the consensus we came to, and we would like others to adopt. That's the first step. The second step is really, I think, petitioning organizations like the World Health Organization, the American Joint Commission on Cancer, to get them to adopt principles and practices that we felt were important, such as, for instance, grading the peritoneal tumor separately from the appendix tumor, making that clear in their documents, because many pathologists do turn to those organizations for guidance and guidelines for how they should practice. We are going to continue with the Delphi process. It became clear even in Amsterdam that there were still some things we don't do correctly or uniformly. We showed cases of tumors to each other, and some people said I would call that low grade, and someone said I would call that high grade. And you're like, oh, it's clear we don't have the same criteria. We're not all following the same rules. And so as part of that, not only are we going to continue with the surveys, but we have started doing cases electronically. So someone loads a case electronically, sends it to all the participants vote on what is it that you would call that, and so we can see what other people would call something, and hopefully, again, gain some uniformity so that when you see something, you would call a rose and not a peony, and everyone knows that's what we're going to call it. When things look somewhat similar and people have different rules for what you call what. And so with that, I thank you for your attention, and one of the only nice pictures I have managed to take in Amsterdam. I'm a pathologist, not a photographer.
Are you going to be able to stay for the lunch?
No.
Okay. So first of all, that was amazing. All I can say is your medical students, your residents, your fellows are incredibly lucky to have you, and if I could bring you to clinic with me, it would be wonderful.
For a price.
Yeah. That's an incredibly hard talk to give, and that was so wonderfully done. Dr. Misdraji can't stay for the lunch, and we have a few minutes, so if there's any questions for him, please, we'll take them now. So thank you.
You're welcome. And I can stay for the break, certainly, so if you want to ask me during break. You mean my personal, like my work email?
Yeah, or something we can get some of your studies.
My studies are probably available if you Googled me. But but if you want any information, can I tell you my email right now and you'll get it?
And also, this lecture is going to be online ultimately, right? So this will be available through the PMP research.
Yeah, and I can
website.
also give you my email as well. That's not a problem.
If you want to review it and study the pathology again, get on the electronic exchange of different pictures.
Sure, it's J, if anyone else is taking this down, JMISD, as David, RAJI, at partners.org. Partners, Partners Healthcare, partners.org.
All right, well, there's a question.
Do any of these classification issues have ramifications with insurances?
Absolutely. Absolutely. So when I told you the reasons for calling something cancer and the reasons for not calling it cancer, I mostly stuck to what the pathologists and clinicians and surgeons sometimes argue. And absolutely, there are all kinds of ramifications that people have mentioned. Like at Basingstoke, a lot of patient advocates mention the concern that they have that patients want to know what they have. So there's patient issues in terms of some surgeons say, I don't want to tell a patient he has cancer. Other surgeons say, I want to tell a patient he has cancer so that they will accept the fact that they have an aggressive therapy ahead of them. There are insurance issues. Sometimes they'll say insurance won't cover this if it's not cancer. And other people will say, oh, but once you mark someone as having cancer, then they can't get life insurance. And so it goes all ways, and it's a really difficult area. So there are definitely social issues that go along with this terminology that impact patients, and I didn't cover that, but that's a good point.
All right, well, we've come to the break in our program, so please help yourself to refreshments. The restrooms are